going to segue into our research in progress presentation, the last part of the lab meeting. Great timing, like you said, Laura. So Laura is going to be giving our presentation today using some data from the OB Motivate Clinic, which we're really excited about, kind of exactly what I was just kind of talking about. And Laura, I'll let you kind of introduce yourself and give, for people that don't know you, and then give your presentation. And again, as always, we do welcome feedback. This paper has not been written up, nor has it been presented yet. We are going to be presenting it soon at a meeting. So, any feedback you have about its presentation or data points that are important or things to kind of think about interpretation wise, this is the time, because we are writing it up for presentation and manuscript right now. So I'll let you take it over, Laura.
Well, hi guys, this is a veteran crew that we have tonight, so I'm excited. My name's Laura, if we haven't met. I'm a 4th year medical student and an Ivy Lab veteran. I am surprisingly applying into OBGYN. So today, this is my second Ivy Lab appearance. Today, I am going to be presenting a project that I presented in August of last year, which feels like an eternity ago. But I'm excited to be bringing the results to the table today, and would love to hear, especially Erin's thoughts on how to do this graphically. So this project is called an integrated care model for pregnant and postpartum people with opioid use disorder. And because this is such a veteran crew, I won't belabor the point. I think you know most of these background points, but I wanted to reshare this figure, right, from Davita Schiff paper. And what this figure is really showing us is that the rate of overdoses and overdose deaths is really increasing and spiking even at that late postpartum period. So that's 7 to 12 month period. And this figure in this paper is what kind of got me thinking about, like, well, what is that all about and where's that coming from? And I know that that's something that Dr. Martin thinks about quite a bit. So what are we doing about this? We're doing a lot of things about it for sure. But one thing that the Ivy Lab does so well is an integrated care model. And so what does that even mean? It means that we're co-localizing our treatment services to make sure that our patients have greater accessibility. So there is literature in lots of chronic diseases like diabetes, HIV, cancer, etc., of how patients can access their care better if it's all in the same place. And so if you've spent any time in the Ivy Lab, you've seen patient doors swing just back and forth with providers of different disciplines coming in and out, making sure that they can get their care. So what is the point of this study? So our first aim in this study is just to describe what that service utilization looks like. There some services that patients are really using and others that they're not? Or there's some that are packing more of a punch? And then we wanted to explore the association between that service utilization pattern and buprenorphine continuation at 6 months postpartum. So I think about this project as what's in the secret sauce? Is there something that is weighting more heavily than others, and can we redistribute our resources to make sure that we're taking advantage of that? So our first outcome that we're going to be looking at is the actual pattern of service utilization, and then secondarily buprenorphine continuation at 6 months postpartum. So we'll talk about how all that is defined because it's quite a bit, but we'll be using the OB Motivate registry data, which you guys are all very familiar with, so I won't beat a dead horse here, but longitudinal chart review data from patients who are on buprenorphine with opioid use disorder, which is such a treasure trove because if you've read this literature, you know that longitudinal data is really hard to come by. So how did we select our patient population? Well, we needed patients to start buprenorphine during this current pregnancy, so people would be on a more even playing field. They needed to be on their buprenorphine in the 3rd trimester, and they needed to have 6 months postpartum data so that we could measure that. So we did end up excluding a few people in the registry who had a 2nd pregnancy, so we just used that 1st pregnancy. And several patients delivered before their 3rd trimester, unfortunately, so they were excluded as well. But at the end of the day, we had 42 patients who had data out through 6 months postpartum, which is crazy. And we had 26 patients who had a full year postpartum. So by virtue of the way we define these, those 12-month people are in that 6-month data set. So what does integrated care look like at OB Motivate? So I wanted to talk about the variables that we're going to measure today in 2 different contexts. I wanted to talk about it in the integrated care context, kind of from more of the provider side. And then I also wanted to talk about it from the patient perspective. How are they experiencing these services? So starting at the top with prenatal care, several of the variables that are in the registry are related to prenatal care, and that can be traditional prenatal care, like we think about prenatal labs and seeing your OB provider. But from an addiction medicine standpoint at OB Motivate, this includes things like neonatal opioid withdrawal syndrome education, lactation and anesthesia consults, plan of safe care planning with our social work colleagues, and everyone should be intimate partner violence screening, but that's neither here nor there. Mental health care is a huge part of what OB Motivate does. So we decided to measure that in behavioral health visits and/or psychotropic medications. And then those all-important wraparound services. These are variables in the registry that are trying to capture care coordination, trying to capture social work in a different way to make sure that we're really kind of showing how hard all of these people work for our patients in a really accurate way. Contraception, and that means specifically in this context, postpartum, which will be more clear on the next slide. And then overall for this study, how many of these services did they use? So because of the complexity of these variables, all of them were turned into a binary. They were either present or absent in the specified time period, which is what we'll get into next. So this is how a patient would experience these variables. So from 28 weeks gestation, so you've entered your 3rd trimester of pregnancy up until delivery, are our first 7 variables. So again, those more traditional prenatal labs, seeing your provider, but the more specific addiction medicine pieces as well, with the NOWS education and the different consult services that OB Motivate offers. So those are the first 7 variables. Again, binary. Did they happen or not within that time period? And in the postpartum period, we have 3 other variables. Did you at least have 1 postpartum visit, which is unfortunately the recommendation right now? Did you have behavioral health visit and/or your psychotropic medication? And did you have access to postpartum contraception? And then at any time during that time period, from when you entered the 3rd trimester to when you were 12 weeks postpartum, did you have intimate partner violence screening documented somewhere in your chart? And was a social worker interacting with you or a legal body on your behalf, and or any of that care coordination that we know is really the glue of what makes this work so well? So now that we've talked about our 12 variables, again, binary, of service utilization, how do we measure buprenorphine continuation itself? So we are lucky to have prescription monitoring programs where we can tell if you have a buprenorphine prescription. So if you had a buprenorphine prescription at 6 months, you were considered to have continued your buprenorphine at 6 months postpartum. So let's get into what our patient population looked like. So we had 42 individuals. So this is people who had 6 months of data postpartum, and surprise, they're reproductively aged. They are predominantly non-Latinx white, unemployed with a high school education or more. They're residing at home. But I think this slide is really interesting that this cohort of the registry, 95% of them have a psychiatric comorbidity, which makes that mental health piece, those variables, even more important. About 1 in 5 of them had another comorbid use disorder. And I wanted to pull your attention to this initiation of therapy variable. So that original paper that I showed you the figure from, Davita Schiff, she did another paper on a bigger scale. She's working with state level data, like you are, Erin, from policy. And she found this cutoff time period to be statistically significant, whether patients had initiated their treatment greater than or less than 4 months approximately to delivery. So I draw your attention to that to show you that our sample was 50-50, which is great. So they were equally represented, and that was important. And 60% breastfeeding at discharge, which I just think is great. And then what do the infants look like? What is this birth experience looking like? A little bit later to prenatal care, 18 weeks at their first prenatal visit, but plus or minus 9 weeks, so a widespread. These are full-term babies for the most part that were delivered vaginally. But for our addiction medicine piece, we're looking more here at the bottom, that there was a 62% diagnosis of neonatal opiate withdrawal syndrome. And the mean stay for the infant in the hospital was about 10 days, but again, plus or minus about 10 days. So a little bit of a range there. So this is a very overwhelming table. Don't worry, I have pre-attentive processing cues built in. But we have on the left-hand side our 12 variables that are organized by time frame as the patient would have experienced them. But where I first want to take your attention is at the top. So out of our 42 individuals, 29 people had continued buprenorphine at 6 months, which is a 69% continuation rate, which I think is really cool. And then I want to pull your attention to the bottom, which is our overall service utilization. So how many services are people using altogether? And between the groups, we can see that it's a fairly similar rate, about 6.5 to about 6. So similar in between the groups, but a high utilization. So this is almost 7 and 6 out of 12 services total. So certainly higher than what I thought they would be, but you can see some individual variation in variables that the clinic is doing a really great job at, and some that we're still trying to figure out logistics wise how to make these processes flow a little bit easier. But just as an interesting aside, we only had 26 patients, so we didn't end up doing any kind of chi-square analyses or anything on this. We just wanted to present the data as exploratory. Again, I want to draw your attention back up to the 12 months postpartum. 16 of those people were retained, which is a 62% continuation rate, which is awesome. And then back down to the bottom at our service utilization outcome, which again is similar overall, but that's a really high service utilization when we look at it from a global view. So then we wanted to look back and see, well, what, if anything, out of our model is affecting treatment continuation at that 6 months postpartum? And we found that length of treatment is the only significant contributor to that, which unfortunately is really well established in the literature already. So we are adding to that literature here, but not breaking any crazy barriers here. So a couple limitations of our study, COVID. I mean, the dates for this were June of 2019 through June of 2021. So we encapsulated all the crazy in this. So we know in almost every part of medicine that this affects how patients access their care. It just does. Also, some new faces during this time. So Margie, Dr. Tyson, Dr. Ryan all came in at different times in this longitudinal period. So capacity certainly increased. And even within a small registry, we had an even smaller cohort. So it's hard to generalize even to our patient population, but still really exciting to get some preliminary data on people who are kind of the first wave of people in the registry. So the take-home points. Overall, the service utilization was high when you average those groups together. That's 6.4 out of 12 services for people who did and didn't continue their buprenorphine. Again, buprenorphine was high, which we're really excited about to see some concrete numbers. and no specific service nor a specific service utilization pattern was associated or could predict buprenorphine continuation at 6 months postpartum, which I, initially was like, darn, I thought we were going to have this crazy silver bullet. And then I came back to what Dr. Martin always says, that there is no silver bullet. That's kind of the whole point, is that this is an individualized, patient-based approach to everything we do. So I think that these findings are really exciting because it shows us that patients are able to access the services that work for them and really maintain what they want their life and autonomy to look like while they're in their treatment. So I would love, love, love to hear everyone's feedback and thank AB so much for her hard work on all of these statistics and coaching me through it.
Great, thank you, Laura. It's so good to see data. Yay! It's been a good day for me, seeing lots of data. I'm excited to hear what feedback people have, as again, we're looking at how to best present the data and the conclusions from the data, etc. And again, also, I'm going to echo what Laura said and say a big thank you to Annabeth, who has been working with Laura and mentoring her through this project too. So I'll open it up for any feedback that people have.
Hey, that was great. Can y'all hear me okay? I'm on a walk with my dog as I listen. So,
Yeah.
That's really exciting. And I had a question, 2 parts. One was, why did you decide 6 months as kind of the point of interest? And then did you look at how utilization was for those who didn't end up staying the full 6 months, but had some utilization in the postpartum period?
Yeah, good question. So one of my pet peeves, and I know Dr. Martin's pet peeves, is that we define postpartum as 6 weeks in a lot of studies. And so we knew that we wanted to do more than that. And we were kind of looking at the study numbers to find a good balance of where we'd have enough statistical power to do what we want, but go as far as we could in time, because we're really trying to build this postpartum literature out farther as we can. And yes, we did look at people kind of just exploratory. Well, I did, because I didn't want to make AB do it. I looked at people who had less than 6 months data, and I didn't do anything close to the formality of this, but it was a lot of similar utilization patterns out to that 12 weeks postpartum. So I don't think it would have changed it that much, but moving forward, all of those people are kind of aging, right? So it's kind of cool because the longer we wait, the more participants we have in the registry. So I don't know if that answers your question, but that was my thought process initially.
Yeah, thank you. I think it would be important when you write it up just to either include that as a figure in the table, so it kind of validates that it's not just a kind of selection of who ended up staying, but it's more generalized to the everyone.
Yeah, thank you.
Yeah, and I think more of a limitation for this data set, and Laura and I have talked about this, compared to the data that you've been working on, Hannah, like the other database, is not everyone consents to be in the registry. So every patient at OB Motivate is approached for participation in the registry, which involves the very lengthy chart abstraction. But a lot of patients decline that. And so for obvious reasons, they don't want the data and research, that's their, lots of reasons behind that. So, but there's definitely selection bias in who's in the registry. And I think that's where most of the bias is coming, is who's being in the registry versus patients who are not in the registry. But we don't have the patients in the registry, their data, because they're not in the registry. So, and it's hard to get that data through the means of the health system. And then I think the other thing, Hannah, too, is, the bias from your analysis with the incarceration, for example, was from who was staying through 6 months or whatever the follow-up was, is important. This one is based on just time has not passed enough yet. So, but I think you're exactly right. It'll be very, very important to just nip that in the butt very clearly, Laura, in your paper about who was selected and how and who didn't end up being, because that's going to be the #1 question.
Did you do any separate analysis for the people who had the psychiatric comorbidities? So just to see if they had any specific predictors of service utilization or any specific service? Because you said you had 95% of people who had that, right? So I'm just wondering if behavioral health or something like that pops up as, and I don't know if you can club people together to get a bigger number, because you're looking so specifically just on that psychiatric part, but just thinking if that something that you can go into later and see if something comes out of that.
Yeah, that's a good point, because that's a good thing that you know about a patient at the beginning that you can stratify them by, which is what clinicians like. Okay, it's on my list.
Great talk, and I really liked your data visualization.
I'm glad it worked out that way.
Yeah, it was really nice. I may have missed it for a second, but did you talk about insurance status and look at that and whether insurance status changed during the postpartum period? Because I know a lot of times insurance status can change depending on the rules and regulations for the postpartum period.
Yes, you are absolutely right. The data that is in the information in the original demographics table is at delivery. Because of the way that the registry is built, there is a big like at delivery form that gives us a lot of information, and we kind of use that as a baseline in the data. But you're right, I would be interested to see how it changes, because we do have insurance status on each 30-day period. So we could technically get that information and see how it changes over time. Yeah.
Right, like potentially having a variable that says whether that person's insurance status changed or not.
Yeah, certainly. Because I think it's 94% are on Medicaid. At the 94% of the patient population are on Medicaid. So I'm not sure if that would change, but that is a really good point.
Okay, great. Thank you.
Thank you.
Yeah, I think that would be super interesting. I think it's 60 days. I should know this, where if you're getting Medicaid just because you're pregnant and you don't qualify, like if you're between 138% and 250%, you will be kicked out of Medicaid. So that might be an important point to look at, like that, just so you don't have to look at every 30-day period, but just at the point of when someone would be likely to switch off of Medicaid.
That makes sense. Thank you.
I had a question about your psychiatric comorbidities. I didn't know, one thing that crossed my mind was, wow, that percentage is really high. But then I thought, well, maybe that's a benefit of being in an integrated model of care, is those folks are more likely to have their mental health needs recognized and documented. So do you know whether those, I don't know, I don't even know if there's a way to tell if it's new or something that, you know, a patient has been living with or seeking care with for a long time, whether that preceded the pregnancy or is related to their pregnancy. So that was something that crossed my mind. And then the second thing, I wondered, so looking at your results, it seems to me that the integrated model of care has really reduced the fractured nature of care seeking for these folks who are in this like super high risk period. So I didn't know if there were any other, I don't know, candidate data sources within VCU, maybe through the CCTR, through like an EHR data pull, or maybe the all payer claims database, where we could maybe look at, I don't even know if you can tell, but so it just crossed my mind. I wonder if we're not seeing an association because everybody is just getting really integrated care. But if we compared it to folks who were seeking these services elsewhere, it would be all over the place. They'd be seeing lots of different providers. They wouldn't be receiving these same level of, wraparound services. So things like that. So that might be more of like a next steps, future research, but something that crossed my mind. So I thought I'd put it out there.
To be motivating, I just reviewed a paper recently, I think it just got published, that there is a protocol that got funded by some HHS grant and for a trial, a clinical trial, a multi-site clinical trial at other institutions where they're kind of looking at this, if that makes sense. So, which is great in the clinical trial form, right? Because you can have, and people are randomized by site. And so they're going to be looking at kind of more traditional care, like integrated models like ours, like everything is under one roof. You have someone coordinating everything. And then another one is like more of a handoff situation, and things are maybe they're there. You have people have access to things ethically that you have to have that, but it's not all under one roof. And so warmly handed off, I guess. So people are looking into this because I just reviewed that paper recently, which is exciting. So this will be even more data to kind of just keep that going, because you're right, the evidence for this it's like what we talk about all the time, but the evidence is not really there. And so it makes it hard to get like health systems and payers, for example, to reimburse. Not every state has an arts program that reimburses so well for care coordination, for example. So I think this is, I'm glad people are working on this and getting money to do it.
Erin, I think for your mental health question, it's confusing and hard to tease apart because Dr. Martin talks about this a lot. Sometimes people come in and they have so many things going on and are potentially in withdrawal and just getting started on their medication. And so it might be a little bit before even their like a mental health diagnoses kind of are able to be teased apart from other stuff that they have going on. So it's kind of a continual work in progress and hard to like put a timeline on exactly what was going on before and what's new and kind of when all things started.
However, in the registry, I believe we do mark if treatments, like someone's on Zoloft, for example. I think we have it marked they're either continued or they're started on it. So it's documented. We did think about that ahead of time. We didn't think about everything, but we thought about, things being started by us versus something that someone was on. Now they're in our care and we continued it, like Zoloft. So we do have that type of what changed when they came here. We do have that.
Yeah, that's true.
What other feedback do people have for Laura? This has been really helpful.
Maybe it's just on my mind because of our research looking into acute care use, but are you able to tell whether folks had any other utilization outside of the Motivate Clinic?
Yeah, I think we have an option, right? Whether you started the medications at VCU or was it outside of VCU? We do have that, but do we also have it for other treatment options?
Yeah, it's just dependent on what the provider reports in the medical record and like what the patient reports to the provider and then what the provider charts, since it's all by chart review. So we capture that as best we can, but I think most of it is for mental health things and like AA or NA if they're doing that outside or like residential or intensive outpatient treatment kind of thing. We try to capture that, but it's just whatever's reported in the chart.
I was thinking too, Laura, kind of maybe Erin made me think of it in her presentation, and I don't know if we've talked about this already. I can't remember, sorry. Is if there were, for the level of service utilization, I know, again, like Erin was saying, like we have a mean of around 6. Like were there chunks of people like on the level, because it's a count variable, it's like what, 0 to 12. And so were there chunks of people that landed at like 2 and then 4, 6? I don't know. I'm just wondering like how the groups land in their service, in their level of service utilization with that count variable. Do you know?
I'd have to ask AB what the raw data was.
Yeah, I was gonna say, I don't think, I have to look at it again. I don't remember off the top of my head. I think it clustered more towards the middle, like it clustered more towards like the true average. But I don't remember. There might have been like groups, because nobody got everything, because there was a couple of things that like people aren't doing, and then some people no one had 0 because there were a couple of things that everyone got. And so I think it was a little bit closer towards the middle. But yeah, I mean, we could definitely do something with the data to present it more individually, I guess, or broken down besides just the mean.
That might be useful. I was thinking like if there's chunks of people at certain levels that you could group them, and then maybe just showing their BUPE trajectory, right? Like how long they stayed on by those subgroups. And then of course have the mean, like maybe what Erin, like examples like Erin was showing. I'm making this up. Like if Erin was showing like the shaded lines in the back, right? And then the mean line, which is everyone. I don't know if the line graph, but something, whatever type of graph you're using, and then maybe having those subgroups shaded in the background, and then to have the overall, just to show like this is what people used, because that's your first aim, and second aim was this is how long they sit on Suboxone for, So just from a descriptive standpoint, that would fulfill those aims, and maybe show that kind of take home, because our take home point is individualized care, like I was talking about earlier. So maybe that could make the graphs reflect our take home point, which is individualized care.
Yeah, I can definitely look at that a little closer and see what we can do.
Great. Okay, anyone else have any other comments or questions? Anything else for Laura? Well, great. Well, Laura, great job. It was exciting to see some data and get such, thank you to everyone for your feedback. It's very helpful and lovely, and will definitely be really helpful as we move forward with Laura's project. And thank you everyone again for tuning in. I know it's late on a Monday night, but I appreciate everyone being here and tuning in to our lab meeting. We're excited. And then Bhushan, do we know when our lab meeting is next month?
I'll have to check one second.
I know we wanted to be better about, I think we picked the 21st of March. I think that's what we picked. So that is the tentative date, is March 21st. That's what I have on my calendar, at least, for the next lab meeting. And so we hope to see everyone there. And then I don't remember what the presentations are, but Bhushan already has that figured out, and we'll send out an email. Great. Well, I hope everyone has a good night, and I will see everyone.